Good morning, everybody. Welcome to Grandrounds in 2022. For now, we're still meeting here, but if things change, we might move to more of the Zoom format again temporarily, but let's hope we can continue to attend in person. Today, I'm very excited to introduce Dr. Laura Youngblood to you. To start off this year's Grandrounds, Dr. Youngblood obtained her medical degree from UTHSC in Memphis and did her residency at this institution. And apart from a brief stint at Memorial Hospital, she's been with us since and is now an assistant professor of medicine and the chief of the Division of General Internal Medicine. And today she'll be talking to us about high-value care. Laura.
Thank you, Dr. Sethi. So high-value care, where's our money going and why should we care? I'm actually really excited about this topic. Any of those that work with me, especially my residents, know that I really enjoy just trying to find the value in what we do. Been a couple of years that I've been really delving into the meat of this topic and really enjoyed last year being able to do a curriculum with the residents going over the information, because a lot of this is not something that you get trained in. It's something that you have to learn over time. And I think that you'll find as we go through this that there's a lot that can be taken, especially right now dealing with the constraints that we're dealing with because of COVID. So I have no disclosures. The objectives for today: understand the definition of value, define healthcare waste, recognize the economic burden of healthcare cost and waste, and then what can we as physicians do? Now, unfortunately with technology, this next slide, which is one of the most important slides, is blank. So I'll be going over it with you from my computer. So you get a nice blank screen to look at. So basically what I'd like to do is give you a couple samples of articles, each one that was unique in their discussion of healthcare expenditure and the cost in the United States. I chose 3 that you don't see up there of the many because they represent the overall theme that I want to go through with this lecture. So one of the first ones was called Healthcare Spending in the United States versus Other High-Income Countries. This was in JAMA in 2018. And basically what it states is when compared to other wealthy countries, the United States spends disproportionately more money on healthcare. In 2016, the US spent nearly twice as much as 10 other high-income countries on medical care, yet we performed less well on many population health outcomes. And that first article compared us to the UK, Canada, Germany, Australia, Japan, Sweden, France, Netherlands, Switzerland, and Denmark. The second article that you can't see is called The Challenge of Understanding Healthcare Cost and Charges. Basically, it discusses the incredible challenge that it is to understand healthcare costs in the United States. And we'll be covering some of the unique obstacles that not only patients, but physicians face as well. And then the last article was called High-Value Cost-Conscious Healthcare. It was concepts for clinicians to evaluate the benefits, harms, and cost of medical interventions. And it's a great article for clinicians to learn and think about what our downstream effects are of the medical interventions that we are providing. Now, for a slide that you can actually see. So more money, but poorer outcomes. So in 2016, US healthcare spending was around 3.3 trillion. That was over 10,000 per person, accounting for about 18% of the GDP, which is the highest in the world. It was 2.5 times the average expenditure among industrialized nations. So more money, but poorer outcomes? Yes. Life expectancy in the United States is lowest at 78.8 years versus ranges for other countries being 81 to around 84 years. We have the highest infant mortality at 5.8, so leading towards 6 deaths per 1,000 live births versus 3.6 for other high-income countries. An estimated 440 Americans die annually prematurely due to preventable harm. And US adults receive only half of their recommended preventative care. So hospital care alone, which everybody knows I'm a hospitalist, so that's where I'm most interested, is responsible for 1/3 of healthcare expenditure, amounting to around 1.1 trillion in 2016. And you're probably saying, Dr. Youngblood, Laura, it's 2022. Why do I care about 2016? Well, knowing our past helps us create our future. So by 2026, national health spending is projected to reach 5.7 trillion. So out of that 3.3 trillion stated here, 1.1 is hospital care directly. Healthcare in the United States is unfortunately fraught with complexity, complexity, fragmentation, inefficiencies, unexplained variation, and then most importantly, waste. So the sobering reality is that a third of healthcare delivered today may not make people healthier, and a substantial portion of that unnecessary care may even cause harm. With this in mind, the IHI created what was first the triple aim. So it was to improve patient care experience, improve health of the population, reduce per capita cost of care. And then with time, they recognized that there should be a fourth aim in this, and that is improving clinician experience. Because how can we achieve the first three if we don't have clinicians that are able and willing and have the gumption and energy, despite their hard work, to actually work on the first three? So with these sobering facts in mind and the hopeful goals ahead, we'll delve into the meat of this talk and start to figure out what the issues are and what can we do about it. So let's start with value. Value is neither an abstract ideal, nor is it a code for cost reductions. Our next objectives will take us through the definitions of value. So value should define the framework for performance improvement in healthcare. We'll talk about the value equation, we'll talk about quality, and we'll talk about cost. So what is the definition of value? It's outcomes relative to cost, all right? In healthcare, this means value is something that adds quality life years, disease-free or disease managed. For some, how well you live is more important than how long you survive. There should be quality in life and dignity of death. Often, value gets misunderstood to always equal lower cost. High cost does not necessarily equal low value, and vice versa. There are high cost interventions that may provide excellent value if globally they are highly beneficial. Think screening programs here. Do you think a GI colonoscopy is cheap? No, but think about the economic burden of advanced colorectal cancer. Also, immunization programs. That's a huge one. Sorry, Mike Davis back there. So low-cost interventions may have little or no value if they provide little benefit and then increase downstream cost. So the value equation, this might be one of the most important slides that I have in this entire talk. Value is quality over cost. So what is quality? Quality is the benefit to the patient, AKA the outcomes. So the outcomes are the numerator of the value equation, and outcomes are inherently condition specific and therefore very multidimensional. For any medical condition, there's no single outcome that captures the results of your care. Cost is the denominator. This is the financial or non-financial, and I have in parentheses harms. So cost refers to the total cost of the full cycle of care for a patient's medical condition, not the cost of the individual services. So let's talk about cost, because terminology here is really important. Cost reduction without regards to outcomes can be a dangerous and self-defeating process, often leading to false savings and potentially limiting effective care. So cost is the actual dollar amount that a provider requires to deliver a healthcare service. So how much it actually takes to deliver a healthcare service. As we all know, charges are very different than cost. This is the financial amount that the healthcare provider or their system that they're within asked for that service. So think about a contractor or anyone working outside of the hospital. You don't take your car and expect to get your car fixed at base cost. There's always going to be a percentage added on. You don't get a contractor to work on your house and get it at base cost. There's going to be a percentage added on. And we, most of the time, do not know that percentage. Reimbursement is the amount that a third party, i.e. insurance, negotiates as payment to the provider. And then price, this is the amount that the actual the patient pays out of pocket. This is the hardest number to estimate, but matters most to our patients. And why does it matter? Because medical bills are the leading cause of bankruptcy in the United States. And 78% of those who file for bankruptcy, secondary to medical bills, actually had insurance at the start of their illness. So let's get an uninsured patient's perspective. This is actually Julian McCullough, who's a comedian, and this was presented on told, a storytelling show in New York City, as heard on American Life and NPR. So he's a 28-year-old male with a severe abdominal pain. He's healthy. Why should he have insurance? He grew up in a family without insurance. Give it some time, it'll go away. Well, he did. He gave it time and it wasn't going away. So he had to go in. Hopefully this plays.
So they finally, on the fourth night, I go into surgery at like 2 a.m. I come out of it.
Is there a way to turn up the volume?
So they finally, on the fourth night, I go into surgery at like 2 a.m. I come out of it. And I'm like, doctor, I really want to go home. And he's like, oh, yeah, you can't leave until you have a bowel movement. And I was like,
what happens when you,
so they finally, on the fourth night, I go into surgery at like 2 a.m. I come out of it. And I'm like, doctor, I really want to go home. And he's like, oh, yeah, you can't leave until you have a bowel.
There is some controls over there.
Sorry, guys, technical difficulties. Yeah, I wonder if I can make this less technologically challenging. Yep, that's what I'm about to do. Let's see if I can do this somewhere.
Bowel movement. So they finally, on the fourth night, I go into surgery at like 2 a.m. I come out of it, and I'm like, doctor, I really want to go home. And he's like, oh, yeah, you can't.
Sorry, guys, it's actually playing now, but it won't go back to, sorry, technological difficulties. Can I get this back to presenter's view? I think it's actually playing. This is the best part of my lecture. It's at least this funniest part.
Can't leave until you have a bowel movement. And I was like, this is the weirdest standoff I've ever had. Eventually I do, I get home, and what you should be wondering, if I were you, I would be wondering this, how much, right? No health insurance, 7 days in the hospital, emergency appendectomy. Well, I'll tell you, it was $45,000. And I found out when I got a bill in the mail for $45,000. By the way, in the mail, with the other mail. Like it was just more mail. But it was a bill for $45,000. In a white envelope like all the other envelopes. That should not come in a white envelope. That should come in a black envelope with a skull and crossbones on it. And when you open it, a picture of your hopes and dreams falls out and bursts into flames because now you owe the hospital $45,000. My friends had a lot of great financial advice. They were like, like across the board. They were like, don't pay it. What are they going to do? Put your appendix back in? And it was tempting, but I had to do it. I'm doing the right thing because I was literally going to die, and they saved my life. And it didn't feel right not paying them back. So I'm doing the right thing. And today I am still paying them back $20 a month. And if Beth Israel Hospital ever wants to see $45,000, they just have to make sure I live to be 657 years old. So balls in your court, Beth Israel Hospital.
Sorry. Technology these days makes it harder.
It's on presenter view. Okay. Ah, there we go.
There we go. All right. Sorry, guys, for that. So, unraveling the veil of healthcare cost. So, have you ever been asked by a patient what the cost of a test you're about to run is? I have. And I definitely have absolutely no clue because cost is not set. Healthcare economist Reinhart referred to pricing in the U.S. hospitals as chaos behind a veil of secrecy. So the actual cost of studies is not set nationwide. It has a wide range of variability that is determined by a multitude of factors that physicians and patients are not aware of. So while pushes towards transparency exist, there is still wild and unexplained variation in pricing between institutes within a city, cities, and states. And there's been absolutely no universal willingness to share that data. So what do people pay? We're going to talk a little bit about insurance here. We have insured versus uninsured, as you just heard. So the uninsured are the only ones that see the direct charges of what you have done, all right? Otherwise, if you have insurance, you're seeing, a portion of it. So uninsured versus uninsured, does insurance make a difference? We'll talk a little bit about the Affordable Care Act, Medicaid, Medicare, private insurance, and employer coverage. These are your options for health coverage that we have right now. So with health insurance, you're not paying the full charge, but a copayment or a percentage of the charge depending on your insurance plan. This makes life fairly challenging when anyone tries to answer that question, hey doc, what's this going to cost me? Even if the doctor knew what the charge was, which we don't, they certainly wouldn't know the specifics of that patient's insurance plan. So insured versus uninsured, pre-ACA, who were the uninsured? Okay, these were adults without dependent children, those in low income families or moderate income families that were too high to qualify for Medicaid, but too low to afford private insurance. And then those without access to employer sponsored insurance coverage and undocumented person. The ACA, its aim was to decrease the number of uninsured Americans and therefore reduce healthcare cost. We all know that this was passed in 2010, upheld in the Supreme Court in 2012, 2015 as well. It called for expansion of coverage. It had the individual mandate, which was removed in 2017, but became effective in 2019. It called for Medicaid expansion. So it took the Medicare qualification from being less than 400% the poverty level to qualifying for less than 138% the poverty level. And it created healthcare insurance exchanges. These were competitive markets with information to assist those that were looking for purchasing insurance. And that was subsidized for families that were less than 400% the poverty level. So what are our insurance options these days? The ACA, there are still exchanges. There's Medicaid, Medicare, private insurance, employer coverage, and then veterans coverage. We are not going to go over the difference between these in detail because that's honestly a lecture in and of itself. But what we are going to see is, did the access to healthcare make a difference? So what you see on your left side here is the uninsured rate among non-elderly from 1995 to 2016. The average was around 17% of the population was uninsured. What you see down at the bottom is around 2013, a year after the ACA was started, you see a drastic drop from averaging around 16.5 to 17% down to 10% by 2016. So on the right, you see barriers to healthcare among these non-elderly. These are people that don't qualify for Medicare by insurance status. These are statistics from 2015, once the ACA had been going for a few years. And you see some stark differences. The very top, the dark blue, is the uninsured. The lighter two blues are Medicaid or other public insurance or employer or other private insurance. So the top one is really important, no usual source of care. So these are people with no what we would call medical home, okay? 54% of uninsured have no medical home. They have no usual access or source that they can use to get medical care versus 12 to 13% of those that have any form of insurance. Did not see or speak with a medical provider about their health, 46% of the uninsured versus 12 to 15 of those with some kind of insurance. Went without needed care due to cost, 20% versus 3 and 8%. And then they went to the doctor, but then they postponed or did not get the prescriptions that were recommended, 20% versus 6 and 15%. So did the ACA meet its aim, which was to decrease the number of uninsured person? So it went from 16 to 70% to 10%, all right? So the uninsured have been shown to have fewer regular medical visits and preventative health screening. They are also known to have lower survival rates for breast and colorectal cancer. They have increased mortality, which is likely owing to greater morbidity from undiagnosed and unknown medical conditions. And they receive less care during a hospitalization. They are less likely to receive a costly test or procedure, and they have higher in-hospital mortality rates. Now, this higher in-hospital mortality rate, once again, is likely due to the disease states once they present. They're in later stages before they officially get diagnosed. I know that I've seen my share of middle-aged or even young people coming in that get diagnosed in one hospital stay with uncontrolled diabetes, hypertension, CKD, heart failure, the list goes on, and they had no clue that this was happening. I'd like to move to the next section with this comment. Warren Buffett has likened the healthcare cost to a tapeworm eating at our economic body. National health expenditures, particularly waste, divert major resources from other important domestic projects, such as education, infrastructure, research, and other public goods. It drags down our global competitiveness in business and thwarts social programs. So with that, we're going to move on to waste. We've discussed value, we've discussed cost, but I started this slide, the slide you couldn't see, discussing how much we spend. Does it surprise you that back in 2009, 30% of the GDP was considered healthcare waste? All right. This statistic is from 2009. We've made some improvements, as the most recent statistic from 2021 is averaging around 17, excuse me. But imagine if we had stayed on that track from 2009 with no changes. The current GDP is approximately $9.5 trillion. 30% of that was way too many zeros for my iPhone calculator, but I believe is around $5.8 trillion. There's a recent publication in JAMA that discussed low value interventions and estimated that as much as 760 billion to 935 billion is low value intervention. This puts us back at that dangerous range of 25% again of total healthcare cost. Overtreatment or low value care with no benefit, or the more sobering thought, care that may cause harm, is estimated to be between 75 billion and $102 billion. These areas of waste include misprevention, fraud, inflated prices, excessive administrative cost, ineffective delivery, and unnecessary services. I'm about to give you a much more sobering fact here, and that 53% of healthcare waste is physician driven. Are you astounded by that? This is unnecessary services that we are doing as physicians. Labs, imaging, prescription, redundancy of care. That is a big one. How often can you have a patient come in that says, "Doc, I just got an echo a month ago." "Oh, you can't get it, might as well get another one." So why would we be the drivers of this? We've all been trained for numerous years. Surely we know what's right and what to do. Nope, it gets broken down to diagnostic uncertainty. And then I would like to break down that diagnostic uncertainty into 3 areas. So the first area is knowledge. So discomfort with your diagnostic uncertainty, therefore you order more. Just a general lack of knowledge of the cost and harms. We talked about how hard it is to even know how much a study cost. No training in weighing the benefit relative to cost and harm, and then the desire to be complete. Nobody wants to miss something. As far as I know, very few people come into medicine to harm others. Process, preemptive ordering or rushing, unnecessary duplication of test, and then this is a big one, ease of access to services while inpatient. Incidental lytic lesion on L3. Sure, let's send them for an MRI and go ahead and get that CT guided biopsy. Why not? Culture, this is really big too. Duplicate role model behavior, faculty demand, defensive medicine, and then patient request. That's a really common one as well. "Doc, I was supposed to get an MRI next week. Can I just do it while I'm here? I don't want to have to come back." So there have actually been studies watching practice patterns as physicians, the same physician goes between institutions. We'll give an example. Say there's a physician that practices at all 3 institutions in Chattanooga, Erlanger, Memorial, and Park Ridge. And what they've seen is that that physician will change their practice patterns depending on where they are. Does that make sense? If we're all practicing evidence-based medicine, shouldn't you take your practice pattern from each hospital? But we don't. We change our practice patterns based off of where we're practicing. That's culture. So diagnostic uncertainty increases resource use, increases ordering, increases physician anxiety, which completely goes against the fourth aim I talked about improving physicians' experience, and therefore equals higher cost. So moving now, let's define waste. Anything that costs money but does not improve or change a patient's outcome. Remember, outcome is the numerator of our high value care equation. In healthcare, this is care that does not benefit a patient, or even worse, may cause them harm. So, excuse me. In 2000, the Institute of Medicine, which is now known as the National Academy of Medicine, released To Err Is Human. This is, everybody hopefully has heard of this. This publication brought to light that at that time, around 98,000 to 100,000 people die annually due to medical errors. This is the first time that this had been brought out in public. Now that number is up to true 250,000 deaths annually, but it's considered grossly underreported and maybe as high as 440,000 deaths. And what To Err Is Human recognize is that it's not bad people in or providing healthcare. It's good people in bad systems that need to be made better. It also brought forth and made more common the definition of what we call a Sentinel event. A Sentinel event is any unanticipated event associated with a healthcare system resulting in harm. So this could be physical or even psychological harm or death that was not related to the natural course of the patient's illness. Let's go through a patient example here. So Mr. B is a 57-year-old currently admitted for concern for pneumonia. His chart indicates that he had C. diff and was treated 3 months ago. He comes in and he does appear septic. He's got fever out of 101, normal tensive, non-tachycardic, but has a white count, chest X-ray with a lower lobe infiltrate. You know, you're covering. You're almost done. It's your last day. You're trying to get your orders in, and your Epic sends up a flag when you order those antibiotics that the patient's had C. diff. You reflexively order a C. diff test and move on. You forget to check out to the team that the patients had no abdominal complaints and no loose stools. The new team comes on the next day and the sputum culture is negative, but there's a viral panel showing metapneumovirus. So now you're thinking, okay, viral pneumonia, you stop the antibiotics. But the C. diff assay comes back positive. So they're sent home with a course of metronidazole. Well, the patient completely didn't understand that the metronidazole was not for his pneumonia. So despite having serious side effects of nausea, vomiting, inability to take PO, and abdominal pain, they persist in trying to take it because they think it's treating their pneumonia. 4 days later, they have to come back to the hospital because they're so dehydrated, they've got a pre-renal AKI. They're rehydrated and then switched to oral vancomycin due to intolerance of flagyl or metronidazole. So, you know, you think that study really didn't cost much. Surely it didn't have much downstream effects, right? Just a C. diff assay, $38, metronidazole for 10 days, $36. Oh no, it cost the patient $70. But the downstream effects was that not only did they miss multiple days of work, they had to come back to the ED and spend another 24 hours getting rehydrated. Then they got sent out with a prescription for Vanc, which is like $2,000, not to mention the unnecessary suffering for the patient and lost days of work. That is a Sentinel event. So cost is not just financial, it's social as well. Missed days of work, travel to and from the hospital or office. You know, not everybody gets to walk out and just hop in a car to come to a doctor's appointment. A lot of them have to plan everything based on public transportation. So all of this is the cost of our healthcare system, and we have to think about how it affects our patients. So we may not be expected to know the ins and outs of all potential costs to each patient, but we still have an ethical obligation to help our patients navigate the substantial barriers and the side effects of our care. So in 2001, this is the Institute of Medicine, they also released Crossing the Quality Chasm. This looks deeper into the quality of care that we provide and goes into the design of some systems so that we can provide better quality of care. Then in 2013, they put out Best Care at Lower Cost, which really prioritizes high value care and how we can tailor our systems to better meet this need. Around this time in 2012, the ABIM Foundation led a call to action. They developed the Choosing Wisely campaign in 2012, which I hope most of you guys are familiar with at this point, especially since every medical society has published the 5 things that we do for no reason. There's an easy app that has both patient information as well as clinician information. So I think that's really important. So the call to action, physicians must lead in addressing these problems because we're 53% of the problem. I really think this next statistic is kind of funny. 3 in 4 physicians say that over-ordering is a very serious problem. It reminds me of that Crest ad they had forever ago. 4 out of 5 physicians recommend Crest over Colgate. And eventually they made a commercial where the 5th physician was asleep. So hopefully that 4th physician was asleep and didn't realize what they were saying. 58% of physicians think that we are in the best position to address this problem, and we are, especially in this situation where we're addressing our trainees, because these guys are coming out and we should be the front line of this, helping the systemic issue. So the goal of the Choosing Wisely is to promote a dialogue with patients and doctors regarding their care. What you want is evidence-based, necessary, non-redundant, and non-harmful care. And each subspecialty has a list of 5 things. So I'm just going to go over the Society of Hospital Medicine's 5 things. 1 is don't perform repetitive daily labs in the face of clinical lab stability. 2 is don't order continuous telemetry monitoring outside of the ICU without a protocol that governs its continuation or discontinuation. This next one, I get on my soapbox about: avoid transfusions of packed red blood cells for arbitrary hemoglobin and hematocrit levels in the absence of active symptoms or active coronary artery disease, heart failure, or stroke. Next, don't prescribe medications for stress ulcer prophylaxis to medical inpatients that are not at high risk for GI complications. Lastly, don't leave in place urinary catheters for incontinence or convenience or monitoring output for non-critically ill patients. You should measure their diuresis using daily weights. Good luck with that. So there's also been a price transparency movement. In 2013, Time magazine published an expose of healthcare cost, Bitter Pill, Why Medical Bills Are Killing Us. Shortly after that, the Secretary of Department of Health and Human Services did an unprecedented thing, and they actually have made available the 2011 Charge Master for the 100 most common inpatient treatments of all hospitals that treat Medicare patients. So this movement has continued forward, thank goodness, with the development of several websites and tools that provide information to patients about the charges they could face for visits and procedures. This is just a small list of the many resources that are now available. So Welcome to Fair Health, drug price comparisons, and online pharmacy safety. This next one is 5 cost of care medical treatment. This is actually allows for cost planning. Transportation, that's really big. How am I going to get to and from these appointments? So for Neighborhood Navigator helps you figure out how you can get to your appointments. And then most of us have heard of GoodRx or other things, looking at prescription prices, comparing them. This list of resources is just a small group, but it's really great because you can basically go in and say, how much is this going to cost me? Okay, I know I'm headed into 50. My primary care says that I need a colonoscopy. So how much is a colonoscopy in Chattanooga going to cost me if I do it with Erlanger versus Memorial versus Park Ridge? Because the prices are going to vary. And it actually will give you some data on what it costs here compared to other areas. And then that can actually allow for a patient to start cost planning and figuring out. And this is something you can help them navigate, because once again, you don't know their insurance. So they can put in whether they're uninsured or have insured, they can put in their insurance information, and they can actually get a gross estimate of what they expect to pay out of pocket, which will allow them to plan for this rather than just having it sprung on them, like that letter that came with the bill for $45,000. So what can we do as physicians? Well, 1, never forget our ethics, never forget our Hippocratic oath, do no harm, try to do good for our patients, help patients maintain their autonomy, and then justice is always important. So I really think that this next slide is something that I had not seen taught as much as it was when I was in residency. And this is also Institute of Medicine developed this, which I said is now the National Academy of Medicine. And this is the STEEP recommendations. Our goal should be to provide safe, timely, effective, efficient, equitable, and patient-centered care for all of our patients. So that brings us back to our numerator of the equation, which is outcomes. They should be patient-centered. This image here does a lot for me. So not only is that patient the center of this, but look how many physicians are around them. Have you ever thought through how many people a patient encounters? These are non-medically educated people who are ill when they enter a hospital system through the ER. All right, you've got somebody screening them. Then you finally get to the ER. You meet a tech, you meet a nurse, you meet a nurse's assistant, you meet a resident, you meet an attending. Then you get a consult, you meet an ortho resident, you don't meet an ortho attending, I don't think. Then you get admitted to medicine, all right? You meet a med student, you meet a resident, you meet a senior resident. You haven't met the attending yet. Now it's shift change. You've got a new nurse, a whole new ER team. Now the attending comes in. They have no clue who you are, all right? One of the biggest things that I try to talk to my residents about is introducing yourself every day, ensuring that they actually know what part you play in their care, because we have really complex patients here. They may have neurology, cardiology, nephrology, medicine, and surgery following them. They may see 20 plus people in a day, not including the nurses and the people and the techs taking care of them. Are they really expected to know who I am? Not really, because there's so much going on, and they're also ill and they're recovering from whatever malady has brought them here. So remember that patient-centered is not just, communicating with them, but it's communicating and make sure that somebody is able to talk to them clearly about the plan, knowing what the surgical plan is, knowing what the orthopedic plan is, knowing what the renal plan is. That means that there's somebody, and I take it upon our team as the primary medical team to be that communicator, to say, this is the plan for the day, this is who we are. So continue with outcomes. Patient reported versus system reported. System reported seems kind of scary, doesn't it? All right, it can be a scary thought for physicians, but it's incredibly important to enable and accelerate learning and improvement in healthcare delivery. Physicians may worry what an outcome will reveal about their practice patterns or even their knowledge, but they need it to understand the opportunity is to learn and to improve. We need it to understand that we have to identify successes and failures in order to gain critical insights about how we practice and how can we improve. So putting in place measurements like process improvement methodology, process analysis and outcome measurements, these allow for feedback, creating learning processes, and enabling one's patient outcome to inform treatment for the next patient of a similar circumstance. Physicians and systems that do not track outcomes for their patients lack the feedback and tools to enable change when needed, which is the fundamental tenet of value-based healthcare, to get better results for your patients and to do so efficiently. Process improvement methodology is widely used in other sectors of the economy, but less often used in healthcare. And what we've seen is when it is used in healthcare, it is often only applied within silos, departments, or procedural areas, rather than across the full cycle of a patient's care journey. So outcome depends on many factors within and aside from health services. So say a patient comes to the ED with an acute MI, and they have shortness of breath and crushing chest pain. But let's actually say they got atrocious medical care. They had delayed EKG. There were lab errors, took them a long time to get an IV in labs. There was slow return on the results because, well, we're understaffed and there's nobody in the lab. And then there was slow follow-up because they shift change. But say their pain was addressed really quickly and they got a dose of morphine and a nitroglycerin sublingual. That patient may view that as a good outcome because their pain and their shortness of breath was addressed with the medicine, but the actual care itself was potentially wasteful and harmful. So there's 4 things here looking at process analysis and outcome measurements. Process measures what is being done in giving and receiving of care. For this to be valid, it must demonstrate a better outcome. Next is structure measures. This is a hard one right now. Resources needed and available for delivery of that care. MRI machines, we're a level 1 stroke center. MRI machines, are they available? Hospital beds, yes, they're available. Available staff, please. Balancing measures tries to ensure that changes do not result in unintended consequences. I really like this one here because This was an unintended consequence of something. A system push to DC before 10 a.m. actually led to an increased length of stay in many circumstances by 1 day. So I'm the discharge queen. Everybody knows it. I feel that a discharge in a hospital system that has to have throughput is a discharge no matter what time it happens. There's no reason that a patient should sit for an extra 12 hours because it's 9 p.m. Okay. Outcome measures are the actual effects of care on the health status of patients and populations. And outcome measures are needed to know what works, and process measures are needed to know what inputs and activities achieve those results. So moving forward, to understand a problem, you first need to measure the right things, meaning you also need to ask the right questions. This is really important for establishing and measuring patient outcomes. Transparency in reporting the effects of change is important to engendering trust. And then changing the way things are done in medicine can be difficult, but transparently reporting those results from a change in practice and showing the improvement goes a long way to increase the willingness to continue to try new approaches. So what can we do? We can redirect our questioning on satisfaction from how were we to how are you? Redirect the focus back to the patient and the results that the patient received, not just question how was your physician or how was your physician's team, or even how was your service. Remember, service can be great and the medicine can be atrocious. So how can we improve our patient outcomes? Patient outcome measurements. There's a couple of definitions here. There are 3 categories that can be specified. These things can be collected just as easily as current patient satisfaction is. The difference with these is that we get insight into how well our patients are doing with their health, rather than how they reacted to the ability to find parking, waiting times, or hospitality. I'm not saying that those things are not important, but to be able to provide true value, we need another focus. So capability refers to the functional outcome such as survival, recovery, ability to perform activities necessary or desired in day-to-day life. Capability matters both during the care and as a result of our care. Comfort, lessening the burden of disease or injury. This includes physical and emotional pain or suffering during or after care. And then calm, lessening the burden of treatment or the burden of the healthcare system. This includes measures related to the amount of time or days lost to treatment or to managing care or to figuring out payment, the ability to work, and the amount of chaos introduced or avoided. So what can we do? Well, we can talk to our patients. Who has time for that? We can implement patient-reported outcomes. One thing is to determine our individual patients' priorities. What makes each day special for them? What are they looking for? Follow-up questionnaires. These can be included embedded in the EHR. Do you understand your care plan? This can be inpatient or outpatient. Do you understand the medications that were prescribed or changed and why? Symptom burden measurement. Give it a few days with the new medication and an auto-populated message that checks in to see how they are responding to it. Get them out of the hospital. Give them a few days, see how they're doing at home. Check-ins after medication adjustments or changes. Making it about the patient's symptom management, especially those with chronic diseases, having follow through. Notice I didn't say follow up, but follow through on the care plan that you created can go a long way to improving not only their clinically measurable outcomes, but their perceived outcomes, which in all honesty is what matters to each individual patient. So our goal is patient-centered care. You may have done a great job on that total knee arthroplasty, but if the patient's reason for getting it was that they wanted to be able to get up and down off the floor with their grandchildren to play, or they wanted to be able to take their dog for a walk in the park, and that's not the outcome they got, no matter the reason, whether it was because of the surgery or not, they're going to perceive it as a poor outcome. If you know why they proceeded with the intervention, and you have a system that can alert you that maybe they're not progressing well with PT, and you're able to step in a timely manner and address those concerns, you've given them a chance to help them get to their goal and improve their perception. This will be the hope for true patient-centered, high-value care. So with that, I'm going to leave one final slide reviewing the value equation. Remember, value is quality over cost. Quality is the benefit to the patient or our outcome. Cost is the financial and non-financial harms. goals that I want you to take from this is to think about cost and how can we make it more transparent. The biggest thing is waste. We are 53% of this problem, leading to billions of dollars of unnecessary services. It's okay to say, I don't know. It's okay to call a colleague. There's no way with where we're going in medicine. Look at the developments we've had over the last 2 years with COVID. No one person can know it all. Something else I say to my residents, when you walk in this hospital or in your clinic, you leave your pride at the door. There's no room for pride in medicine. There's nothing wrong with saying, I don't know, and looking for the answer. It is wrong to say, I don't know and walk away. It is okay to say, I don't know and continue to ask and learn and strive and look for the next step and the answer. Remember that quality is the benefit to the patient, not how well you did, but how well the patient did because of the care. And then value, it is not always synonymous with cheaper if the outcomes are poor. So this is my list of references, too small for anyone to read. And with that, I will end. And I think we have a few moments for questions. And I will leave you with that because that's a much better backdrop.
There's a new push that we ought to be transparent and willing and able to tell patients ahead of time, what will this visit, this procedure cost? Do you know much about how that's going to work? Because we're about to have a psychiatric group office meeting, and it sounds crazy and chaotic. Much as I think it's really good to be transparent, how are we supposed to estimate the cost for an episode of depression or an episode of mania? We've never met the patient. It's a real challenge.
Yes, exactly. That is one of the biggest challenges because, like I said, at this point, cost is still not set. And, you know, we really have no clue what the studies are. So there, as I listed, there are some resources online. I've actually got several saved that I'll be happy to share with anybody. And you can go through and you can put in their information. You can put in what they're, what you're, looking for. And it will give a gross estimate. If they have insurance, you can put that in as well. And therefore you can help navigate. One of the resources that I showed, I wouldn't be able to find it right now, but one of the resources I showed actually allows and helps with cost planning. And there's a website that I've got listed in here in my references that actually goes through, put in their age, put in the study. And I don't know how that works for psychiatric care because a lot of this is going to be procedural based, like how much is this echo going to cost me? How much is this CT going to cost me? How much is this, colonoscopy, et cetera, going to cost? And preparing them ahead of time so that they can make those plans. How you do that for a psychiatric condition, I truly don't know. But it really depends, like I said, on insurance, and it'd be a hard one to do. I think there are, fortunately, as we continue to progress with this transparency, I think that more and more resources are coming online and available.
Any other questions?
I got a text question.
Okay.
How do you think the focus on patient satisfaction and autonomy helps or hinders the quest for improved value? I think that is an excellent question because I gave the example of the patient that came in with chest pain who got morphine and nitroglycerin who felt better but had actually atrocious care. So I think there's a fine balance between focus on patient satisfaction. Satisfaction for me is not how long did you have to wait in the ER. I know that waiting times are long. Satisfaction is how are you doing after your care, not how did you feel about your care. So I think changing the question, the way we pose the question to our patients will go a long way. And then recognizing that patients can be autonomous. Not everybody wants to get up and get going every day. That's not everybody's personality. Some people are happy as is. And if you know that that is what they want to be able to sit at home while their family is around them, but they're not necessarily the one in charge of things. That helps you know what their expectations are. But if you know that your patient wants to get out and go back to work, go back to the lumber mill, go back to whatever activity it was. That can help you guide what you're doing a lot better. So I think the biggest way is to change how we're answering or how we're questioning. It's not about their satisfaction. It's about how they did after the care occurred.
More questions? Laura, I've got to say, oh, sorry.
Right, we had 3.
I just wanted to make a comment. I'm Doug Brewer, the Chief Medical Officer of Erlanger Medical Group, and there's a couple of comments. The first is I pay attention to what actually is going on, and we have, at least to me, a younger physician who is becoming a champion above and beyond the care of patients. And we all need to see that and aspire to it, okay? Second, in terms of patient experience, there is much literature that supports the notion that both clinical and financial outcomes from our healthcare are directly related to patient experience. Next, I agree with what you said about patient experience, and we talk about setting expectations. I'm not sure about setting expectations. I agree with you. We should understand expectations. And the simple question on a daily basis on inpatients and people we see in our offices is, what's important to you? Finally, at least to me, this seems to be overwhelming, but it brings back to me the team-based approach. We don't need to be responsible ourselves for all of this. We should lead it, but we should do so in a team-based approach with behavioral health and nutritionists, APPs. That's my vision, and I think it goes in concert with what you presented here. But thank you for your time and your message.
I had another text question that came in. I think it's a great question, actually. Question about legal actions if we take a minimal approach. So physicians that communicate with their patients don't get sued. So if you are talking to your patient and they know that you are engaged and you are listening, even if you take the minimalist approach, because maybe that's what they wanted. I can't tell you how many times I've walked into an end-stage cancer patient with this huge slew of workup, and I've walked into the room and said, what do you want? Do you want to be in this hospital for the next week while we do this? Is this really what you want? Because doing this, it'll give you an answer, yes, but it will not change your outcome. And by communicating with those patients in that manner, I've literally stopped thousands of dollars worth of workup that would not change or affected that patient's life expectancy at all because I talked to them. Physicians that truly talk to their patients rarely get sued. Dr. Davis, you had a question?
Thank you, Dr. Youngblood. That's a really good place to leave it. So I'll give you my question anyway. So are there built and validated questionnaires for follow-up on patient-centered outcomes? And it seems like if there are, implementing them would be a fantastic quality improvement opportunity for our colleagues here in the Department of Internal Medicine.
Yes, so the ACP has an amazing high-value care curriculum, and they actually have how to talk to your patients, a multi-step approach. I think it's like 5 or 6 steps that is entwined into that curriculum. And it is validated tool to working and talking through your healthcare with your patients that can be used. And that's through the ACP. And I'm sure that there are other societies that have already done this. But yes, there are validated tools for how to communicate with your patients about their care plan.
Another reason, as you mentioned earlier, to don't let the patient know who you are, because I've had patients who claim that the neurologist has not seen them the entire week. I take over the service and then know every day from the neurologist. So if you're a compassionate physician and they don't know who you are, then you're not really reaping the benefit of your efforts. So I think it does help to let the patient know I'm the hospitalist that care about you. We're doing our best, and if you miss a test because you're more efficient, you're going to be good.
First, to commend you on your talk for choosing this topic. Your talk comes third in line after Megan Coilwright and Dr. Sizemore, all of whom, like you, emphasize patient-centered care. And I'm glad that that seems to be becoming a movement in this institution. It's incredibly important. I particularly love that slide of the patient in the midst of a circle of healthcare providers and your 3 Cs. I have a question since you talked about the cost of the bitter pill and the medications we send patients on. I'm just curious if our residents are using the Got Meds approach where you supply 30-day, 90-day prescriptions, you give them double the dose, high dose tablets so they can split the pills. You make sure that they don't get pantoprazole in place of Pepsid for what's needed. Are we doing something of that sort? If we're not, that would be a great QI project for us.
Yeah, and I think that's something that should be implemented inpatient and outpatient is looking at, so, using the resources, there's numerous prescription cost resources out there, and, and enabling your patients, giving them that autonomy. There's not I have very few patients I've seen a few flip phones, but very few patients these days don't have some kind of access to internet. So why not go ahead and show them those web pages then so they can compare prices? But yes, absolutely. Go ahead and do a 90-day supply of, 50 milligrams and have them cut it in half. But the biggest thing there too is just making sure that the communication is the correct dose so that they don't get home and take the incorrect dose.
Correct. Thank you.
Thank y'all.